Okay, it's live now.
It's live now. Good evening, everyone. Welcome to our Turkish episode in Al-Ahwa. I will speak at two words in Arabic and we'll continue our episode in English. مساء الخير عليكم جميعا. ان شاء الله باذن الله دي سهره مميزه جدا جدا في برنامج القهوه، ودي مقدمه باللغه العربيه، بس احنا هنكمل ان شاء الله باللغه الانجليزيه. بس انا حبيت ان انا احافظ على الترند بتاعنا في ان احنا بنتكلم بالعربي. Welcome everyone. We need to welcome our dear Professor Dr. Remzi from Turkey, Dr. Sengul, and Dr. Noor, but he is doing her Turkish
preparing her Turkish coffee.
Turkish coffee, and will join us. My dear friend Ahmed Habib, welcome everyone, and we are starting our special episode about the diabetic vitrectomy, what we are doing in a preoperative assessment, what you are doing in a surgery, what's your rationale now for the sections of your membrane, what's your rationale now for your tamponade, and what's your new technique, and what's your new in 2020. And we will discuss all this topic. Welcome, Dr. Noor.
This is the Turkish coffee in a special bottle.
It deserves to spend this time. Okay? It deserves. Yes.
Oh.
Let's start. I will just share this screen just for demonstrating what we are speaking about. Okay, it's not a presentation. It's just show what we are talking about. This is our plan of the episode. Preoperative considerations. We are speaking about videos presentations about technique and modifications. We will discuss the tamponating of choice of everyone. What's the new in 2020 for everyone, and we will conclude our session. This is short. This is the preoperative considerations, and I will ask everyone now what's your preoperative considerations about the indications of your surgery. Dr. Ramzi, you have a special indications now for your diabetic vitrectomies, or Dr. Ramzi?
First of all, I would like to thank you guys. You are doing a great job, as I told before. So really, you are doing a great job. So I follow you on the Facebook. So I think tonight we'll share our experience about diabetic vitreous surgery, and both Turkish and Egyptian colleagues will follow us. Thanks again. For surgical, I have not really special surgical indications, but in general, the most frequent indication in diabetic vitrectomy is vitreous hemorrhage and membrane traction, proliferative membranes, and traction retinal detachment. And we rarely do vitrectomy for macular edema cases, as you know, but there is no real special indications.
Dr. Singh?
First of all, again, I would like to thank you all for doing this great job and giving the name of Turkish Cafe. I liked it also. And I agree with Dr. Remzi Avcı with the indication, but I can maybe add a little bit more. Like I do vitrectomy, diabetic vitrectomy in cases with, for example, neovascular glaucoma with pupillary problem. If you can't, dilate the pupilla because of the neovascularization in the iris or posterior synechia or things like that, and if you can't do the enough laser from outside, I mean argon laser, then I can prefer to do vitrectomy with endo laser to the peripheral retina. And also, I can also do some argon laser to the ciliary body in the same session. So this may be a little bit a different indication for myself. And I can also think about vitrectomy for if I have a very aggressive proliferative diabetic retinopathy without any hemorrhage or any membrane, but very florid neovascularization, and also together with cataract. And if I can't do the laser, I don't want to do the only cataract surgery and do the laser after that, but I usually do cataract surgery together with vitrectomy just to do the laser. Maybe these are the unusual indications for vitrectomy in
So
diabetic eyes.
you need to tell us that you can do a surgery for treatment of a florid proliferative diabetic retinopathy. Just to do.
If I can't.
Yeah. If you can, just to do a complete full PRP.
Yes, right.
Shingil, maybe ask a question before passing the Noor about neovascular glaucoma. You said that you prefer argon laser of ciliary body. So, there's another conventional method that we can apply cryo, transscleral cryo also. So, what's your experience? Really, you believe that laser, standard laser, really works? So, I do the surgeries, as you said, as for neovascular glaucoma in my practice, but I usually prefer cryo, transscleral cryo, cyclocryo. So, really, it's okay, but I would like to learn your experience about with the laser. Yeah.
Yeah, of course. Actually, I have left doing cryotherapy for a long time for these eyes because I also have transscleral diode laser cycloablation. So when I decide to do that, I use the diode laser. It doesn't cause too much, inflammation and too much scarring in the conjunctiva and all those things. These are the pluses of the diode laser. But what I want to add with argon laser is just a little bit more power to the treatment. That's it. That's not the only treatment that I do for neovascular glaucoma, but I just want to add this as an additive part. That's it. If I don't have the transscleral diode laser in my hands at that moment, it's in things like that. But it's not as efficient as transscleral diode laser, I should say that.
Dr. Noor, you have official indications for diabetic vitrectomy now, like Dr. Singhal, he tell us that he doing a vitrectomy for a florid proliferative diabetic retinopathy, and I like this way, by the way.
I mean, if there are neovascularizations, florid retina, and if I cannot think that I can do the cataract, we cannot do laser as well, then we can do a for the because it will progress very rapidly in type 1 young patients and controlled diabetes.
No, there is too much echo.
Yes, I
I
can.
couldn't hear you well. Too much echo.
Absolutely.
Have you connected the headphones?
Yes, connected.
Maybe we just like this. Can you hear me now?
I think now it's better.
Yes, we can.
Now it's better.
It is better. Okay. So, did you hear anything I said before?
No, we
You
don't
can
hear.
start at the beginning again.
Start from the beginning.
Sorry for that. As I agree with you that, but they are really rare cases now. If it is a type 1 young guy, it's a very aggressive diabetic retinopathy, progressive rapidly, and we cannot perform the perfect argon laser, especially in the peripheral area. It can be combined that during the cataract surgery with the treatment, very nice argon laser to the periphery, especially with indentations. It can reach only in the surgery, or with indirect laser we can do that. But if the patient has cataract, we may not do it. In these cases, we can prefer surgery, but I must say that they are really rare now.
Yes.
So can we say that one of the of the mechanisms for the vitrectomy for the florid PDR is the increased oxygenation of the retina and the vitreous cavity?
Yes.
Besides the laser to the the periphery. So do you do indentation when to reach with the laser up to the aura?
Yes.
Or just you just under air go as far as you can.
I mean, you mean the vitrectomy to the periphery as much as
During
I
the
can?
vitrectomy, yes.
No,
During the
during
vitrectomy, you do indentation and laser up to the aura, or you just go as far as you can under air.
As far as I can to the periphery, as much as it, because I, especially in a vitrectomy, in every diabetic eye, I first start with the most periphery that I can during the surgery, because we cannot do it even later with the IOL or the cataract or something else. So the periphery, first I laser with within the surgery. With indentation I can reach as periphery as I can, and then to the posterior side.
So
Maybe ask another.
yes. You can go.
Yeah, Ahmed, go on. Later, then maybe ask another question for florid retinopathy, Nur, both you and Şengül. So in the era of anti-VEGF injection, actually, I do not see florid retinopathy for many years. I can say that, as in theoretically there is florid retinopathy indication for surgery, but in my practice, I can say more for the last 10 years, maybe I don't have any single case like that. You really need vitrectomy for florid retinopathy. Are you agree with me, or you have this different experience?
I agree, but Dr. Ramsey, maybe it can change in the clinic where you work, because when I was in the government-based education hospital, I really see very bad, poorly diabetic eyes. I had a really very much experience, as you all did. But recently, I'm now working in a private university-based clinic, so I don't see so uncontrolled florid retinopathies. Also, of course, anti-VEGFs are also effective in this.
In Egypt, we see quite a few.
I have a little bit different experience because especially in type 1 diabetics, even if they are, in a good condition, if they don't control the diabetes very well, they usually have very florid proliferative diabetic retinopathy with lots of neovascularizations, although they have full vision, but there are, too many neovascularization in the optic disc and all the other areas. I have seen many cases like this, especially type 1 diabetes. So in such cases, you can of course do anti-VEGF, but they are usually active people and they usually work, so they can't come regularly to the anti-VEGF like in elderly patients. So in those cases, they come back with very bad, fibrotic membranes, neovascular fibrotic membranes when they don't continue with anti-VEGF, or if they are left without any treatment, so they come with very florid neovascularization. So especially in those cases, I'm talking about those cases, especially for florid retina. If I see any vitreous hemorrhage or anything like that in such cases, I do vitrectomy as soon as possible.
Yes.
This is, type 1 diabetics. If you try to do laser and, it causes too much proliferation and it progresses very rapidly. So what I do in those cases is when I see some hemorrhage, even if I feel that it may resorb spontaneously within a month or so, I usually try to, force them for vitrectomy, because when you do vitrectomy also slows the progression of diabetic retinopathy. We all know this. If you do a good vitrectomy, it usually slows it. Although you may have some cataract issue, but in young patients, it's not a big deal, it's usually not so quick. So in such cases, I prefer to do vitrectomy earlier, especially if they have some vitreous hemorrhage.
So in other
This
words,
is
the threshold, your threshold for vitrectomy is pretty low in young people.
Type 1. Yes.
Yes. Any small indication that may go away, you just grab it quick because the condition of the retina improves. Any minor traction, if relieved, the vessels will be relaxed and the vasculature will be better. That's what I see. So
you have comment, Dr. Ramsey?
so I think we also discussed about the indication of early vitrectomy. This is very important. I would like to show you a case, Şengül.
Okay.
So, like to also take your idea. For example, this patient. Can you see my screen now?
Yes, yes.
Yes, we can.
This patient, this lady is 25 years old, type 1 diabetes. You can see there is no laser, but there are very active neovascularization, disc and elsewhere, as you see here. So, this is your indication for the vitrectomy right now?
No, there's no vitreous hemorrhage at the moment. Of course, I do parietal photocoagulation, if possible, in one or at most two sessions, and I would add also anti-VEGF after the first session. I do laser as much as I can in the first session, and then do the anti-VEGF injection to prevent any possible vitreous hemorrhage, and to gain some time to do the second session, or to prevent the early post-laser hemorrhage, and then do the try to complete the parietal photocoagulation as soon as possible. That's what I do in
Okay.
such cases.
So what we did in this patient, so we suggest to do anti-VEGF and laser panretinal laser this patient, but the vision was 0.8, and the patient did not accept our treatment. And 8 weeks after this picture, just 2 months after this picture, patient gone with these pictures. So
Yeah.
this area is the exactly correspond this neovascularization area. As you see,
That's
in
what
2
I
months,
mean.
in this patient,
Yeah.
sorry?
That's
Yeah,
exactly
I
what I
understand.
mean.
Yeah.
Yeah.
So in 2 months later, we observed this patient with this picture, very severe vitreous hemorrhage and fresh membrane, not strictly attached to the retina yet. And therefore, I think these are really, as Şengül mentioned, type 1 diabetes with active neovascularization is really we should treat this patient as soon as possible. And
Yes,
what we
aggressive,
did
actually.
then, we apply surgery in this patient just after this picture, and the membrane was not strictly attached to the retina yet. After killing vitreous hemorrhage, as you see, just a simple traction was help us to peel all the membrane. If we would wait a few weeks more in this patient, I think the membrane would be strictly attached, very thick, and membrane would be really difficult to treat this patient. So I just wanted to share this patient because
But
after discussion to say
Dr.
really,
Ramzi, Dr. Ramzi,
yeah.
you now support the idea of Dr. Single about the early vitrectomy in type 1, because we face a problem, especially in type 1, because he's seeing a good vision. He have a good vision, and he cannot he
He's
cannot
not
accept
convinced that he needs.
he is in a problem. We need to do much more effort to tell him that you have a high problem or you are at a high risk, and he cannot accept. If you do this patient early vitrectomy and finish up the problem in one session or in one decision,
So
it's better.
let me say
Or
my yeah, I understand your question, Mohammed, but again, in this patient, the same the first picture. So the vision is 0.8, there are active neovascularization, but there's no hemorrhage. So I think in that time we don't need to do vitrectomy. So we still have a chance to do injection, to do panretinal laser. This
But
is
should be
young patient.
aggressive with the patient. But
Yeah,
he has
but
to be
we should
aggressive with
finish.
treatment.
What plan in this patient? If I this patient like this, I do injection immediately, and a week after injection, start to do panretinal laser. Under the pressure of anti-VEGF, there is no inflammation. I can complete the panretinal laser in a month. Then do a second injection. So most of the diabetic type 1 diabetes, if you do this schedule just after this position, I think we can manage this patient without needing vitrectomy. But a few weeks later, if you don't do anything, I mean that this patient is really progressed very fast, and it's unbelievable. When I see this patient's picture 8 weeks later, I really shocked how did this happen like that. But it may be, and therefore we really be in a hurry to treat such patient in type 1 diabetes, especially in
Let's
this
let's
group of
let's
patients.
ask another question related to early vitrectomy. Now, Dr. Ramzi, Dr. Sengel, Dr. Noor Habib, do you follow a case of a diabetic vitreous hemorrhage, or you decide a vitrectomy once you see the vitreous hemorrhage, Dr. Ramzi?
So this is the topic that I want to discuss with you tonight. So at the before, we do wait a few weeks and see the vitreous hemorrhage and resorb and do laser, something like that. But today we have very good instrumentation. Vitreoretinal surgical techniques became less inflammative and very safe. And therefore, when I see vitreous hemorrhage in such patient, but if I see that if it's not will not clear in a few weeks, I do prefer vitrectomy. But if it's not severe hemorrhage, I do injection, wait several weeks. If it's not clear, then I decide to do vitrectomy. But
So you have two options according to the type of vitreous hemorrhage. One
yeah,
type of vitreous hemorrhage you go through for vitrectomy, and the type you give the chance for anti-VEGF and follow up for 3 weeks to 4 weeks and decide. Am I right?
yeah, but this mean yeah, it's right. Yeah, this severe hemorrhage is we cannot see the retina, and then I decide to do vitrectomies because the resorption of the hemorrhage will take weeks, several weeks. But it's not severe hemorrhage, and we can see the details blur. But and under suppression of anti-VEGF, it will clean in a few weeks. I do injection and wait, and to do laser later on.
Dr.
So in
Single,
other words, if it
Dr.
if it's
Single, you have a chance for a follow up in a vitreous hemorrhage, or you have a one decision is a vitrectomy only.
Okay, it depends on, many factors. First of all, it depends on the type of diabetes. If it is type 2 diabetes, I can consider waiting. Second, if the patient already had some pre-hemorrhage laser, enough laser, I can decide to wait. Another thing is if the patient doesn't have any reverse iridis or anterior segment neovascularization like neovascular glaucoma or anything like that, I can wait. And if I also asked if they had any previous hemorrhages like this, which has cleared quickly. It also depends on the how dense it is, as Dr. Remzalci mentioned. But sometimes you don't see any retinal detail because it's just at the back of the lens. It's not a dense hemorrhage, but you may not see any retinal detail because it's in the anterior hyaloid surface. That's why it can prevent, seeing any retinal detail, but it may not be too dense. So you can also check with the ultrasonography if you have any track. You will, as usual, which is a classical approach. So it depends on the things. And also it depends on the motivation of the patient. If the patient is very motivated for surgery and if the patient wants to have an early good vision, a very active person, needs the vision in the other eye. If it is, if he is a one-eyed patient, of course, very early vitrectomy. So we have so many things to consider.
Patient conditions factors, not a strict factor to do or not to do. But I need to illustrate that what we are doing, what we are thinking before that if in type of vitreous hemorrhage, you need to wait for 4 months or 6 months until it's
we
clear or
used to
not.
say we used
This
to say
type,
that if it's type 1 we
Okay.
wait 2 weeks, and
uh,
if it's type 2 we wait
Dr.
4 weeks. I think this is
Okay.
now subject for change. If you see it's
Right.
very dense, you go for it. If you see that it may go away, you just wait or inject. But sometimes there are a little veil of vitreous hemorrhage that can persist for weeks, and then you're in a pickle. You're not you can't find an excuse to do vitrectomy, but the patient is still not happy, and this can go for months. So what do you do about that?
Dr. Noor, you have a comment about the vitreous hemorrhage before we go for Dr. Habib questions?
Yes, I'm not sure if you have the echo now, but can you hear me well?
Yes.
We hear you well, yeah.
Much better.
Okay. About the vitreous hemorrhage, of course, it depends on many factors, as Şengül mentioned. I mean, if the patient is type 1, young patient, if it is compliant with the treatment, mostly if they see well, for example, diabetic patients, you have to talk a lot with them, because since they are seeing well, they cannot understand sometimes. They have a problem to understand the consequences if we wait, for example. And of course, ultrasonographic evaluation is a must. If there's any tractions in the periphery, mid-periphery, around the macular area, my indication for vitrectomy increases, of course. And the density of the hemorrhage is important. If there's a subhyaloid hemorrhage, it is really very difficult for it to dissolve in a quick time. So I agree. If the hemorrhage is not so dense, I can inject. If there is no traction in the ultrasonography, I prefer to do an injection. Wait for 2 weeks, and every week I also see the patient. And as soon as I can see some free areas, I do the laser. And then if still the hemorrhage doesn't go away and I cannot control the progression, then the vitrectomy in at most in 1 month.
But we need to confirm all of you. Type 1, we need to be aggressive with them. Am I right?
Yes.
Right.
Agree.
Right, Habib. So this is a very clear message. This is a very clear message. We need to be aggressive with a type 1 diabetic vitreous hemorrhage. You need to be aggressive. You don't need to wait for a type 1 vitreous hemorrhage, because this type of patient need a special situation. Back to the questions of Habib, please. Habib, can you repeat your questions, please?
I was saying that sometimes you wait for vitreous hemorrhage to resolve, then it becomes a veil of vitreous hemorrhage with some haze, but then you're in a problem. You can't find an excuse for vitrectomy, but also the patient is unhappy for some time. What do you do about that? You go for vitrectomy and then by the patient, or you wait for the patient to resolve by itself.
I mean,
Good. Oh, yes.
Yes.
we have to talk really very well and briefly, and if possible, not only with the patient, but the relative, the father or the mother or the wife or the husband. I mean, that's like a family issue, So they should understand first, because usually it happens. I mean, they have problems sometimes to understand what we mean. Second, at the end, sometimes, and we should say that at the end, we will do the injection, wait for some time, maybe 1 week, 2 weeks, and if it is getting worse, we should go immediately for the vitrectomy. And in the meanwhile, please go to the consultation with the endocrinologist and internal medicist, just in case we have a surgery, because usually they have a poor metabolic control, poor control. So it gives you some time to prepare the patient for a surgery. I'm talking about at most 1 month. And I was searching by case. I had a case like bilateral, for example, like the case, type 1 diabetes, 45 years old male with bilateral vitreous hemorrhage. When I see the patient, I did immediately pan-retinal laser, both eyes. But the one had a tractional detachment, so it will go for a surgery. And also, what I do, for example, if there's a vitreous hemorrhage, on the same day, I do the laser, and then after it, anti-VEGF in the same day, if possible. And then, for example, for 3-5 days, 1 week later, the second session of endo laser. But the other eye went to the surgery, but I couldn't find the pictures. Sorry.
Dr. Ramsey, you have a comment?
Dr.
No,
Şengül?
yes, Şengül. I can after Şengül, yeah.
Dr. Şengül.
Thank you. Actually, such eyes are usually having recurrent little hemorrhages. That's why it doesn't clear totally. So these eyes usually have some laser already, and they are usually lasered, but they have some small little hemorrhages again and again. So that's why they don't clear totally. What I do for these cases is I usually think that there's some vitreous hemorrhage in one of the neovascularization in somewhere, some vitreous traction causing, hemorrhage, and that's a mechanical issue. That's why it goes again and again. It occurs again and again. So in such cases, I tell them that you already have panretinal photocoagulation, but you still have recurrent hemorrhages, and they come again and again, and it disturb your social life. If you are disturbed with this, if you don't want to live with this, I say that I can do the operation and it can end, most probably. But if they say that it's okay with me, I have it all the time and it doesn't disturb me too much, then I don't touch. So that's the main issue, I guess.
Yeah.
So maybe I can say something, but it's almost same. I just operate such kind of case today. Today is my operation days, and the patient's panretinal laser is completely filled. There is no space to do more laser, but still patient has recurrent vitreous hemorrhage, but it's not very severe hemorrhage. And come to most office, I see that as a little hemorrhage, and wait a few weeks and clear again, happen again. So what we see this patient, when I go into the vitreous, when I see that there is partial vitreous detachment, but some area, there is on the superior temporal quadrant, there is local traction, and there is small elevated vessels, but there is no neovascularization. Small elevated retinal vessels, and the bleeding area was there, and there's small traction may cause vessel tear and small bleeding and stop again. A few weeks later, it's happened again. So in this patient, I think we don't need to do more laser, but we need to do to remove, to release this mechanical traction, and therefore we need to do vitrectomy. If you do vitrectomy, and as also I pay attention to clean the vitreous base with indentation as much as possible. So most of this patient can be happy, because as you said that this patient really unhappy, because a few weeks good, a few weeks bad, and good and bad. But vitrectomy, I think in this patient is really a good indication.
But we can conclude this point of discussion that every patient is a new patient. Every patient is a new story. Every patient have its special story. You have no special or no strict rule how to do, when to do the vitrectomy for a diabetic patient. And this is a conclusion of this point, because we need to go through for another point. Dr. Ramzi, what's your rationale for preoperative anticoagulant control?
So we speak about diabetic patient. Except diabetic patient, I really do not pay attention to stop anticoagulation and other things in vitro. But in diabetic patient, as you know, there's a bleeding problem there also because of the diabetes, and therefore in active diabetic patients. So if some patient has really very inactive retina, laser is already done, and there is some traction membrane but inactive membrane. In this patient, maybe I cannot discontinue, but except this patient, in diabetic patient, I pay attention to discontinue, to stop the anticoagulants like for 5 days before surgery with consultation of their cardiologist, and then do surgery. But in patient, only in patient with inactive retina, only with some tractions on the macula, small membranes, I can not stop, and I can do direct surgery.
Okay. Dr. Sengul, you have a different protocol for anticoagulant or no?
No, completely agree. Nothing to add. Thank you.
Dr. Honor, you have another added point for this issue about the preoperative anticoagulant?
Yes, I agree. And sometimes, even in some cases, the cardiologists say that we cannot stop, so we go on for the vitrectomy.
Habib, you have a comment for this one?
Actually, I need to comment for something. In the cardiology recommendations, this is a minor surgery, and in minor surgeries you don't stop the anticoagulants. That's the recommendations of the of the American Cardiology Society or stuff like that. So you actually don't need to stop it. But sometimes, if the with the new anticoagulants like the Xarelto and some the new generation anticoagulants, it's really I think it's really dangerous to keep it going. I think you have to change, but the older ones, I think you can get by.
But do you agree with me that the blood pressure of the patient in intraoperatively it's much more important than the preoperative stopping of anticoagulant or something like because I working in a patient not stopping anticoagulant and it's not there is no problem, but every single patient bleeding with me intraoperative is equal
Hypertension.
uncontrolled hypertension. It's equal the hypertension of this patient. Do you have a comment, Dr. Singh?
I agree with you that hypertension is very important, to be controlled. And when they have surgery under local anesthesia, if you don't give any sedation or something like that, the hypertension, if it is not under well control, they usually have very hypertensive crisis. And sometimes you may not, stop the bleeding at all,
No,
and
no.
you may need to stop the surgery sometimes.
Yes.
So, but that's why maybe we will talk it later, but I just want to say it in parentheses that I usually prefer to do the surgery in general anesthesia in these cases,
We will discuss
especially in
this
such
point.
case.
So
Yes,
you
we
need,
will discuss
you need
that.
to tell me that you are preferring a GA in diabetic patient, okay?
Sorry?
You prefer
So you prefer general anesthesia?
general anesthesia
General
and a diabetic
anesthesia,
patient.
especially with patients with hypertension and very fluid, neovascular membranes. In those cases, I usually prefer to do it under general anesthesia.
But
And for more
aren't you afraid of the
general
actually
complications.
increase? No, after the general anesthesia, after he wakes up from the general anesthesia, the blood pressure increases back, and you might the next day find a little circle of hemorrhage under the silicone or over the fovea or something. Aren't you
Yeah, of
concerned about?
course, it can happen in both conditions, I should say that. But still, I prefer to do it under general anesthesia. And one more addition for Habib's comment about the anticoagulants is that cardiologists talk like that because of the they assume that it's a minor surgery, but actually in
It's a major.
neovascular
It's a major one.
membranes in neovascular
A major
membranes it's a major one, yeah, and it can
Yeah.
cause too much bleeding, so they may not think about that, they may not imagine that, so that's why we should do that. We can do the macular surgery, macular hole, or maybe retinal detachment, maybe rheumatological retinal detachment with under anticoagulation. But for a neovascular condition, if you're, for example, dealing with choroidal patch graft, or if you're dealing with neovascularization conditions like ischemic retinal conditions, so I always try to, discontinue the anticoagulants and antiaggregants. I
Maybe we
always
should talk
try.
to them. Maybe we should talk to them
Dr.
and
Yeah,
convince them
right.
that
right.
Dr. Ramzi,
it's
I have a
a larger
comment.
surgery.
Dr. Ramzi, you have a comment?
So, I think we already passed another topics like general or local anesthesia or standby anesthesia. But
Yes.
about anticoagulant stoppings, Ahmed, always we do consultation with cardiologist, and again, in patient with active proliferative membrane, if I need to peel it's very severe membrane, this is really major surgery for us. Maybe it's not for cardiologist, and therefore I prefer to stop anticoagulant. It's also important like hypertension, but also important. But except this, if the patient has some risk when we stop the anticoagulants, we can go ahead. Except diabetes, I do not stop anticoagulant in my vitrectomy surgery. So, do we
So do you
say
stop
something
it
about
5 days
anesthesia?
before?
Yes,
You stop
5
it
days
5 days
before.
before, and
Yeah,
you
four
convert to
five days
treatment.
before usually, and also ENR. Also, we look check the ENR, but 4 5 days is really enough to get a safe condition.
Okay.
Let's go
So
for general anesthesia and local anesthesia, Dr.
anesthesia.
Remzi.
So as you mentioned, hypertension is very important during surgery for the bleeding complication. But for more than 25 years, I do 99% of my patients is local anesthesia, maybe 98%. Only children or conscious
Irritable.
people that I do prefer general anesthesia. Why? Because when I started with retinal surgery years ago in the university clinic, it was very active and a very crowded clinic, and I had to do like 17 cases in a week, in a day, vitrectomy,
In
and
a day.
therefore
In a
general
day.
anesthesia was time consuming. Yeah, in a day, like 15 to 17 case vitrectomy I
Oh,
did when I
so
was
fast.
young like you. But now, not now. And I was doing surgery in two operating rooms, and team was ready in 2 rooms, and I start one surgery and leave the closing the assistant and go so like 17 or 18 cases in a day. So this is really was very hard working. But and then I get used to not to take general anesthesia because of the time problem. But today, what we are doing, I do not prefer general anesthesia, but I prefer standby anesthesia. And our anesthetist is together with us during whole surgery and control the blood pressure. And I think this also helped us to control the blood pressure just after the surgery. And in general anesthesia, when stop your surgery, you close the eye, and during this ending of anesthesia, again, the patient has some hypertension, and they may cause the bleedings. And I believe that in standby anesthesia, if the anesthesia is also really good communication with you,
Hypotensive.
I think we can control hypertension much better than general anesthesia. This is my experience in my field.
So you can tell now that you are shifting from general anesthesia to local anesthesia with assistance of your anesthesia to control blood pressure all through
Yeah,
your surgery and post-operative also.
yeah. Yeah, I mean, postoperative, I mean, just after surgery, like a patient takes another room, like stay there for 15
Mhm.
weeks, for 15 minutes, for example. And during that period also, they control the pressure of the patients to prevent early post-op bleeding.
Okay. Dr. Noor, you are also working local anesthesia or general anesthesia in diabetic vitrectomy?
If the patient is not young, I mean, because they are usually non-compliant. I mean, ages less than 40 at my hands are really very stressful. For example, with sedation, if it is a must, I will prefer. But apart from it, I prefer local anesthesia. But I was going to say that Dr. Remzi already told, find a good compliant anesthesiologist, be a team. So I think it's really very important to monitor these patients' blood sugar during the surgery, during, and after. They sometimes decrease suddenly, sometimes increase incrementally, and then the hypertension is also the same. So the follow-up with the anesthesiology, like standby with the sedation, good sedation, and subtenial anesthesia, it's doable very most, especially in the elderly. I wouldn't prefer a general anesthesia also for the patient because they have vascular issues. So it's not good for them to age patients to have the general anesthesia. And likewise, the anesthesiology team follows the patient at least for 4 hours after the surgery in the postoperative resting room also. And if it is necessary to give some medication or else, they would do the same. So I think it is comfortable
So
to
we
follow.
can tell.
So
So
you
we
find a compliant anesthesiologist, not a patient.
بالظبط.
Yes,
This is
yes,
A
what I
compliant anesthesiologist.
yes, anesthesiologist is a important player in your vitrectomy of a diabetic vitrectomy. Can we take some questions from the audience? What about the vitreous hemorrhage in a fluid-filled eye in a diabetic fluid-filled eye? Do you waiting for
Read
this
meat.
hemorrhage?
Meat.
No, not
Could you
immediately.
repeat?
Not immediately. It's
Could you
rebleeding.
repeat, Mohammed, again? I couldn't hear that.
Rebleeding.
It's a vitreous hemorrhage.
Rebleeding.
Rebleeding, not
Rebleeding.
immediately, not immediately after surgery. It's a patient is diabetic. You're doing it the surgery very well, and it's a rebleeding again. And you waiting, or you just go directly to do what we call in vitreous wash or an immediate vitrectomy, Dr. Ramsey.
Um, um, Actually, I can say that I have this complication is really rare, not so many case. But if I have that, I prefer to wait several weeks. Again, depends the patient's retinal condition. If the retina is attached, if there is no another problem, if there is no severe, very severe hemorrhage, we can wait several few weeks. And most of the patient during this period can clear. But if not, then we can wash the vitreous like
I,
2 to 3 weeks after surgery if still persist hemorrhage.
you can agree with me that if you do a good PRP endo laser for a diabetic case, you face a rebleeding is very rare. If you
Yeah.
confine to do a good endo PRP,
I
you
actually
will.
have an experience with this. I have been doing a light scatter laser if it's if I'm not seeing the PDR very advanced, but the rebleeds were a lot. So I converted to a heavy laser with peripheral laser, and the rebleeds decreased by
For
so
me,
much.
this is
Mohammed,
also
I see sometimes, but it's not that common.
let me say something about that. This is another trick in my surgery. When I finish all the lasers and now I've finalized the surgery, I close the infusion and get the eye pressure like under 10 millimeter mercury, maybe eyes getting really soft, and observe if there's any bleeding anywhere. If not, then
Yes, I
I
get it.
stop surgery. If there is some bleeding, I do some more things like maybe mechanical pressure or
Comparative.
endodiathermy. So this is, I think, a very important trick. At the end of
yes.
surgery, we should observe again the old retina, see the risk of hemorrhage, then stop surgery. Really, with these methods, I have really very, very rare case that have severe bleeding after surgery and needs operation again.
Okay.
But you're talking about the post-operative vitreous
Sorry, I
cavity
think
hemorrhage.
um,
Uh,
my connection was not good.
No,
Did
no, it's
I miss
good.
Sorry,
we
anything?
Ahmed.
have you now. We have you now.
No, you are good now.
So we were talking about about
Rebleeding
the
issue.
rebleed, not the post-operative vitreous cavity hemorrhage. The POVITch, or the post-operative vitreous cavity hemorrhage, that's the maintained turbidity after the vitrectomy. But we are talking about rebleeding after a period of clearance.
Of clearance.
Okay, okay. So
I
So
I
mean,
have,
so this
yeah,
trick will
I mean
be
several
helping
weeks
in this
after
also.
surgery. You mean?
Yes,
I
So
yes.
you
see,
mean
I see.
after late vitreous
A
hemorrhage? You mean?
rebleed.
Yes,
Yes.
yes, yes, yes,
So
yes.
Okay,
may
this
I
is
may
another
I
topic.
comment
Yeah.
on that?
You can comment, but
May
the
I
late
comment
bleeding
on
is
that?
another topic. Yeah. But after
Okay,
Şengül, maybe I can say something. Okay, Şengül.
okay. These late bleedings are usually caused by anthracite neovascularization. So this is a very important issue, and it happens between 5 to 15% of the cases in the literature also. And it is different from the anterior hyaloid neovascularization, but it's anthracite neovascularization. Anterior hyaloid neovascularization is much less frequent issue, but this is much more frequent. Why it happens? It's usually caused by the peripheral vitreous incarceration into the sclerotomy sites, and the neovascularization may go into that site because of the ischemia of the periphery, and also in the sclera. Even the scleral ischemia may cause this. And late recurrent hemorrhages are usually secondary to this. And to prevent that, it's better to do the cryotherapy in the sclerotomy areas. It's usually much helpful, and even this is also my experience, but also in the literature, there's a very good, I don't remember the name of the author, but there's a very good paper on this, showing very decreased post-op hemorrhage rebleedings, late rebleedings after doing cryotherapy.
But
So
you're talking about the neovascularization at the retina related to the sclerotomy, or at the site of the sclerotomy, like
Side
scar
of
tissue or
sclerosis.
hamartoma of the blood vessels or something, right?
no, at the
You're
site
saying
of the sclerotomy,
so
usually
if
we
it's
don't
scar tissue.
see it. We don't see it, but when you enter the eye, you can maybe see it. And to prevent that, cryo is a very good option. And also to do the vitreous base shaving in the sclerotomy areas is also another good option to prevent such problems. Even though you do a very good, vitrectomy and endolaser to the periphery, everything, but this can happen, especially in phakic eyes. You can't do the laser to till the aura. So in such cases, this may be a good solution.
Dr. Ramzi, you have a comment?
Yeah, for late vitreous hemorrhage, so I agree with Şengül, but again, this is really rare complication after transscleral surgery. Several years ago, with conventional vitrectomy technique, we observed this complication more than now. Again, cryo, but I do not do cryo regularly at the first surgery to prevent late bleeding, because this is really very rare condition. Therefore, I think the best things for this to prevent this complication to do perfect vitreous-based cleaning. What am I doing in my technique? Most of these patients that also we prefer to save the crystalline lens in place. So in this condition, it's really not easy to clean the vitreous base. I do my sclerotomy 4.5 millimeters from the limbus in phakic
Four and a half.
patients.
4.5.
Yes, 4.5. Because in all of these patients, we do laser, panretinal laser all over the retina. And then we like sometimes 4.5, but usually 4 millimeters is enough. And then I do strong indentation to cross the lens and without touching the lens to be able to clean the vitreous base. I think this is really good technique. With this method, you can clean all vitreous bases perfectly and prevent this complication. But 4 or 4.5 millimeters far from the limbus sclerotomy, and by manual surgery, do strong indentation, and with this technique you can cross the lens to the other side of the eye without touching the lens and clean the vitreous space. This is my technique.
Dr. Noor, you have a comment on this topic? Dr. Noor?
I agree that, yes. Do you hear me now?
Yes.
Yeah.
Do you hear me?
Yes,
yes, I agree, Dr. Ramzi, that in my technique also I do a complete, as much as I shave the vitreous carefully, and even in phakic eyes it is possible, although in the classical knowledge that we shouldn't cross the lens with the opium and everything, but actually you should be careful. It needs patience maybe, but with the strong indentation, self-indentation, the surgeon controls it very well. So it is possible to do a complete vitrectomy, clean especially in the entrance areas, around the entrance areas also, and do the laser with the indentation again, with a curved endolaser probe to the periphery as much as you can. So I really see those very, very rarely, almost.
Can I tell you something? For me, I didn't believe in a complete vitrectomy or complete shaving of vitreous base, but especially in a diabetic cases, the complete shaving of the vitreous and complete shaving all the vitreous is a much more important, especially in diabetic vitrectomy for me. It's a very, very critical step. Before I didn't do this complete shaving and complete removing of the vitreous, and I faced a lot of post-operative bleeding and late post-operative bleeding. But after strict removing all the vitreous, especially whatever it's a phakic or pseudophakic, and like Dr. Ramsey said, in a phakic, if you are allowed to do a bimanual surgeries that you are indent by yourself and you can reach to the periphery very easy, you cannot face this a problem of late rebleeding. So we can conclude this session.
So,
If you need
question for the panel. So, do you prefer phaco with vitrectomy or just vitrectomy?
type 1 diabetic patient, you do phaco-vitrectomy or you do vitrectomy only? It's more difficult question.
So,
More difficult questions.
so may I talk?
Yes,
Oh, yes,
please.
yes.
So in type 1, I always try to preserve the lens.
Yes.
I do, probably I do lots of pediatric vitreoretinal surgery, probably because of that also. I always try to preserve the lens. Even in type 2 diabetics, I try to do the preserve the lens, do the vitrectomy and everything to make the eye in a quiet, bring the eye in a quiet condition, and then you can continue with the cataract surgery.
So you mean
In
to avoid
diabetic eyes, this
the
is my,
rubiosis? To avoid the
sorry?
rubiosis? To avoid
Yes,
the
that's why.
rubiosis?
That's why this is my routine schedule in proliferative diabetic retinopathy, vitrectomy to prevent the post of rubeosis iridis. But if the patient, of course, has a significant cataract, which may, blur my vision during the, of course, I do laser, I do phaco-vitrectomy, but in such cases, I always do pre-op anti-VEGF first. And second, I do a complete peripheral vitrectomy and do laser till the ora serrata to prevent rubeosis iridis. Otherwise, in such cases, you can have post-op iris neovascularization.
Dr. Ramsey, I will make the question more difficult. You have a type 1 diabetic patient and the lens is clear, but you have anterior hyaloid, turbid anterior hyaloid, retrolenticular hyaloid. Let it make more difficult. Retrolenticular hyaloid. And you need to keep this clear lens. What you are doing, you do vitrectomy only and try to don't catch this retrolenticular hyaloid, or what you are doing.
So, first of all, I totally agree with Şengül about the preserving the lens in diabetic patient. This is really, really important, not only to prevent rubeosis, also, this is really very inflammative surgery, vitreous surgery. If you combine the surgery with cataract surgery, you can increase inflammation is much more, and especially on the iris plane, you can see lots of membrane, fibrin reaction, posterior synesthesia, iris capture, lens capture. So therefore, I really do not like to do combined surgery in diabetic patient unless cataract prevents to do surgery. If the severe dense cataract, it's not possible to do surgery, you can do. So for your question, Mohammed, usually, as I said that I work during the last 10 years in the private practice. So, and therefore, usually we observe here very selective case. I do not have such case, but if I would have, again, I try to preserve the lens in place, and step by step with active section of the posterior anterior highlight, and try to remove the anterior highlight from the lens, and then try to eat all the membranes. But if not possible, then we have to do lens extraction. But again, I do my best to preserve the lens in place, especially in type 1 diabetic patient. For this patient, for this eyes, only the method that with high active section to the anterior hyaloid, and you can separate, you can detach the anterior hyaloid from the, yes. First, just on the sections, and take contract the hyaloid through the vitreous center, and then step by step from one side, then the other side, and then remove the hyaloids, and then vitreous base, and go to the vitreous cavity. So this is really time consuming surgery, but we should give time to do this in such patient.
Dr. Noor, we are agrees that type 1, all of us try to keep the lens as much as we can. Do you believe in this also in type 2 diabetes? And if you have a clear lens in 50 years old patient and you are going to do a vitrectomy for a diabetic vitrectomy, do you leave this lens clear? This
Yes.
clear lens?
Yes, I don't touch the lens. As my dear colleagues mentioned very briefly, we want to protect the lens if it is clear, if it is not obstructing the vision, my vision, and also we can reach the periphery as we have already talked and agreed. So it is maybe after 50 years old, the cataract will develop in some time, but then we can manage the cataract separately.
I have a comment on this point. For me, also type 1 is non-touchable lens. If I go for a vitrectomy and my plan is to leave this patient on air tamponade or in gas tamponade, and is a simple vitrectomy, diabetic vitrectomy like vitreous hemorrhage or a small membrane, I would go for a phaco-vitrectomy and to complete shaving the membrane and to complete shaving the vitreous base, to complete do into PRP, and in a point of it's an inflammatory process and post-operative reaction of the anterior chamber. I usually put a 0.1 or 0.2 dexamethasone in the anterior chamber after finishing the surgery, and the amount of percentage of post-operative reaction in the anterior chamber is significantly disappear for me. I didn't see this post-operative reaction for anterior chamber after using this 0.2 or 0.2 dexamethasone for anterior chamber, because I think this phaco-vitrectomy for a vitreous hemorrhage or a simple vitrectomy, we have a feel free to shave the vitreous base and do a complete PRP. But I am totally agree that in type 1, we need to save the lens as much as we can. Okay, we need to go through for the last topic for this preoperative assessment and what your rationale for preoperative anti-VEGF, Dr. Ramzi. You still inject patient or not?
Yeah. So this is another controversial point, prop anti-VEGF injection. There are several studies show some benefits of this injections, like more easy surgery and prevent post-op early bleeding. But also there are some studies show there is no benefit of this prop anti-injection. What am I doing in my practice? I only prefer anti-prop anti-VEGF injection in patient with active proliferative membrane, which needs to peel the membrane. It will also severe membrane. Also, it's a very thick membrane. So if there is no active membrane, I do not prefer prop anti-VEGF injections because I don't think that it really help us in all patients. If the patient has really high risk of hemorrhage during surgery, yes, it's okay. I do that. If not, I do not prefer. But the other point that I usually prefer anti-VEGF injection at the end of surgery in my cases. And I observed that anti-VEGF injection at the end of surgery may help to prevent early post-op vitreous hemorrhage. And therefore, I do this routinely, but also to prevent macular edema after surgery, after a secondary to laser photocoagulation, but not anti-VEGF injection preoperatively in all cases.
We think, Dr. Ramzi, that the anti-VEGF injection in a fluid filled or in air filled, you leave the globe fluid filled or you leave the globe air filled, whatever the tamponade you inject at the end anti-VEGF?
Yeah, if usually I do not, if I prefer air or gas, I do not feel completely the vitreous cavity vitreous. I leave if a small
Partial,
amount of fluid on the vitreous to for the anti-VEGF. But if I prefer silicone oil, I do injection again in the middle of the silicone oil bubble. But again, I rarely prefer silicone oil in such patient.
Dr. Singer, your rationale of preoperative anti-VEGF, what's your rationale now?
Okay. What I do is almost similar to Dr. Remzarji's approach. I do anti-VEGF just 2 days or 2-3 days before the surgery in only the active proliferative cases, not in routine epiretinal membranes, total parenchymal photocoagulation, no active bleeding or something like that. In those cases, I don't do it routinely. And second thing, when I do anti-VEGF at the end of the surgery is, again, in these florid cases, and we have published a study on this. I think it was in 2011 or something like that. We have done a study on that, and it has shown that adding the anti-VEGF at the end of the surgery, you have much less hemorrhage, post-op hemorrhage. We can find it in the PubMed also. So we have done these studies, and it usually it is significantly it has effect. And secondly, I usually leave the eye in air. I think that air prevents the postoperative sclerotomy leakage, and also it may have some tamponating effect on the blood vessels to prevent early post-op hemorrhage. And I also feel myself in a better condition, and probably it also prevents some post-op inflammation also in the vitreous cavity.
Full air?
So I feel much on air, yes.
Full
on air. If I don't have any, of course.
Not partial air.
Usually,
full air.
almost full, I should say.
And
I'm not
you don't worry about the concentration of the anti-VEGF over the retina, only over the retina, when you inject the anti-VEGF.
No, I don't care about that. I don't think it's a problem. I don't think it's a problem. I didn't. I do this at least for the last maybe almost 5-10 years routinely, and I didn't have any issue about that. Of course, I didn't do any study on the concentration in the vitreous cavity, but I didn't have any issue on that. So air makes me much comfortable about the patient also, because patients usually wait to see just the next day. But if you have a little bit post-op hemorrhage or minimal leakage, and you have to explain that to the patient. But when you have air, it also tamponates, and you can explain
and you
that.
Say you won't see before 2 weeks.
Yes, of course. But
Thank you, guys.
It's usually cleared within 5 days or so,
Yes.
the air.
It will be a nice
So
surprise.
it usually goes away, and everything is much easier when you have air in the eye.
Yes,
Dr. Noor, you still inject before surgery, or like Dr. Ramzi and Dr. Singhul, you inject after surgery?
No, I inject before the surgery sometimes, not in every eye, but especially again, we have been always talking young eyes, type 1, florid, aggressive, lot of neovascularizations. I prefer to inject. And my injection time has decreased. Even 1 day works, decreases the bleeding during the surgery, but it's a bit too short actually. 2 days, 48 hours is almost the optimum for me now. And I would prefer to operate before 5 days. After 5 days, even I have a patient I can show it later. I did inject a young type 1 patient, and in 5 days I injected aflibercept this time, because we don't inject only for single dose drugs now, and it worked really very strongly, and it caused traction detachment, macro detachment in 5 days, because we scheduled the surgery on 2 days, but then something happened and it was postponed to 5 days, and I was shocked to see that. And even there's a nice study from England, I remember, after 7 days especially, the fibrous component increases very dramatically. So 7 days may be the cutoff, maybe endpoint should be. So if I plan to inject, what I do is I tell the patient, do the consultation with the endocrinologist, anesthesiologist. I get all the okays from everywhere. So we plan the surgery date for a vitrectomy, for example, 3 days later, and then and only then I inject. Because
that's a great point. You say if we inject you, we have to do the surgery, and we have to to do it in time, not to be late. So the cutoff for for you being late is 1 week, right?
At most,
Not
even
not
5
more
days.
than one. So and Dr. Ramsey, Dr. Singh,
Even
what
2 weeks,
is your
I do
cutoff?
injection like 3 to 4 days before, but sometimes, as Nur said, that some patients come from abroad from a long distance, and I do injection today in the morning and do surgery a day after in the afternoon, 1 day after in the afternoon. So it's okay. But usually, if I have chance, I prefer to do surgery like 3 to 4 days before surgery. So the other topic that I'm really happy to hear that Şengül's study support my observation about the injection of anti-VEGF injection at the end of surgery really prevents the bleeding. So I missed your study, Şengül. So I didn't collect my data, but really, so I'm really happy about that. So really, it helps to prevent this bleeding. And after this routine procedure, I rarely observe early vitreous hemorrhage. Therefore, I really strongly suggest our young surgeons to do this procedure as a regular setup.
But I need to comment about the
Thank
preoperative.
you.
I have stopped injecting before surgery for now 4 years. I stopped injecting preoperative anti-VEGF, and I found that the preoperative systemic condition of the patient is a clue for intraoperative bleeding, not the preoperative anti-VEGF or not. So I strictly controlling about the systemic condition of the patient, hypertension, anticoagulant, whatever. And I didn't find any intraoperative problem for intraoperative bleeding. If I found intraoperative bleeding, I found uncontrolled hypertension intraoperative. So I stopped preoperative injection of anti-VEGF really.
If the patient was controlled regarding the diabetes, he wouldn't have the advanced diabetic disease. So
But
by
hypertension,
definition, they are uncontrolled.
yeah, yes, but hypertension is the much more important. Dr. Noor, you have a comment?
And Mohammed, that's my humble suggestion. But if you have an uncontrolled hypertension, that should be an elective surgery. So, what we suggest, what we do is just try to control this systemically for example, in 1 week, and with a better control, go for the surgery. That is my suggestion for the especially young surgeons, because diabetic vitrectomy, it can be a surprise. We should be ready for the surprises, and there should be a good team with anesthesiologists following the patient during the procedure, and we should be ready. It can be elective. I mean, we should go right for surgery in 2 days' time, but we can wait maybe for a week, for example, just for the regular and every setup, and your should be ready. I tell it for the young patients, young surgeons. So it is. And the second thing about injecting anti-VEGFs, that's what they do. For example, when you inject, the neovascularizations collapse, and there's a pulling of the vitreous. So it elevates even the neovascular planes that you can delaminate easier. Without bleeding, it's the second part, but even it causes some traction. That is why we should be there. It's a really nice study. It is shown that after 2 days, the fibrovascular component decreases dramatically, and the fibrous component of the membrane increases. And in 5 days, after 5 days, like the 7 days, the fibrous component dominates, but the neovascularizations really diminishes maybe 80%. So, I mean, it is effective, but hypertension, I agree, it's really a major concern that we should be taking care of it. I agree.
The problem with that is we can't really compare between patients that injected or not, because every patient is different from the other.
Yes.
You can't make the denominator one. So I think it's difficult to compare. It will always be a controversial point, I think.
Okay, let's start to inside the surgery, and we now controlling the systemic condition of the patient, and now injecting the patient, and 2 days ago, and the patient hypertension is controlled, and in a general anesthesia or local anesthesia, and Ahmed Habib have a demography for his plan of dissection of the membrane. Ahmed, you have a show now?
Yes. So I'll first talk about the uni-manual vitrectomy for fibrovascular perforation. Then, sorry. Um, then we will talk about the bimanual. So first, uni-manual. My plan usually um, is to do circumcision around the posterior membranes to dissect between the central membranes and the periphery of the vitreous, and then um, I remove the peripheral vitreous. Sorry. And then I remove the peripheral vitreous. And actually, if I'm going to do shaving, I do it at this point to avoid if there will be any breaks in the posterior pole and the retina elevates. Then I will not be able to do shaving as I want. So I usually circumcise around the peripheral, around the central membrane, and remove the peripheral vitreous and do shaving at the peripheral vitreous, and then attack the membrane. First, I don't attack the membrane from the disc or over the fovea or over the main vessels. I usually find some bridges and cut them off, and then trim loose ends, loose membranes, and again find new bridges and repeat that. Cut, trim, and repeat. So usually I do this. I don't remove the stump over the disc to avoid bleeding. This is my main problem and main nightmare. And I remove piece by piece the bridges from underneath if the membrane uh, is formed of bridges, not broadly attached. Usually, I use the 25 gauge and small gauges because they can insulate themselves under the bridges and in small areas. And that's usually my technique if it is uni-manual. So let's ask the panel about the uni-manual surgery. What do you do
Dr.
if
Ramzi.
if it's uni-manual and the
Uh,
bimanual is not
this is a
available?
very good surgery, Ahmed. I have some difference than your technique. Uh, I do not do unimanual surgery for maybe more than 15 years, and I almost always work bimanually with
Hmm.
wide angle viewing system and with extra illumination like twin light, chandelier illumination, card twin light, and to visualization is very important. And therefore, again, I do not leave the membranectomy at the end stage. When I do, as you, 360-degree separation of the membranes from the anterior part of the vitreous with partial removal of the partial detached vitreous around the membrane, I do not go to periphery of the vitreous space. I do not spend time there before doing membranectomy. Why? Because in diabetic patients, during the end of surgery, we observe corneal edema and the view is getting blurred, and therefore I stop my work on the macular area on the membranectomy. I do just after this core vitrectomy, do membranectomy, then go to vitreous base shaving
But
because it's also take time.
you do the
Sorry.
circumcision between the you do the
Yes,
circumcision between the center and the
yes, yes, I do first. This is the first step because if you should do this because you should release all the traction between membranes and the vitreous space. When you release
yes.
this traction with the 360-degree circumscribe vitrectomy, then go to membrane. And also during membranectomy, I start almost always from periphery to the center, from out to in. And again, so there are many techniques. So you use here this old probe this dissection you prefer in this case. Yes, I prefer old probe dissection, do with membranectomy with vitrectomy probe, old membranectomy, but in selected case, not in all case, because my standard technique is bimanual membranectomy in diabetic patients. And because I can see the surgical plane is very clearly with forceps and scissors, and I can see the bleedings, and also there is some studies with all probe dissection may create more iatrogenic tear. So some surgeons really very familiar on this, but I do not prefer in such severe case all probe dissection. Maybe if we had a good experience, we could do that. But in my hand, my optimized surgery is by manual dissection, and with this surgery, I did many cases, and I reduced my complication, and I therefore I do not want to change my technique with new fashion technique. Therefore, I still continue there. But in
But you,
some
but
selected
you
cases,
don't
I
peel. You
prefer
don't peel.
all probe dissection.
But you don't peel. You don't pull on the membrane as we used to with the 20 gauge from the disc and you just pluck it off. You don't do that, right?
Uh, Actually, I would like to ask you a question. What's your experience about iatrogenic tear and also bleeding, uncontrolled bleeding during with this technique? Uh,
In the,
I think
with
maybe
this
also
technique,
depends your experience with this because I do not apply this technique in more, many patients. Therefore, maybe I do not have enough experience. But if I happy,
no,
so this is my
I was
technique. I
actually
always
with the bleedings. I don't pull over the disc because the only uncontrolled bleeding was is from the disc in my experience, and I don't actually attack it. I just leave a stump over the disc. But with the peripheral membranes, it is my practice that if there is a small bleeding point, I cauterize at the spot on the spot. I don't leave it to pool the blood to turn into membranes. I just cauterize it each by each. But I was asking about if have you removed the membranes? Do you sometimes remove the membranes by peeling? You pull in the membranes by the forceps and you just peel it off the retina. Do you do that? Because we used to do
no.
it in the 20 gauge vitrectomy, but now
Yeah, but
I stopped.
so in maybe we will show out a video also
Yes.
by manually forceps and scissors, and you can see all the surgical planes clearly. You don't not peel uncontrolled peelings. You
I totally
just
agree.
tract and see the cleavage plane, see the connecting points, and you can just cut it. If you see some bleedings, you can decauterize. But during this period, also several weeks, minutes, I pressure, high the pressure, increase the pressure of intraocular pressure to prevent bleeding during membranectomy. Again, if I can do, I try to do end block dissection to prevent bleeding in this patient also, but it's not possible in all the times. But as I say, I'm old generation surgeon. You can say that I did thousands of patients with this technique, and really it's optimized in my hand. And I pay attention to standardize all step of my surgery in all surgery, not only in diabetic patients. And therefore, I do not have huge experience with all probe dissection or viscodelamination, for example. This is another new technique.
Yes.
But again, if I
Do what
see
works in
that
your
there
hands.
is no complication with conventional method, I usually rarely leave that method and go to another method. And maybe I don't like to look for an attraction, something like that. So, but this does not mean that this technique is not good. But in my hand, my
Yes.
technique is bimanual dissection. My
If it
gold
works with
standard
your hands,
is
it's okay.
yeah,
Yes,
yeah.
I'm good.
Okay, so it was very nice discussion. So I enjoyed to listen you. First of all, the surgery was really very elegant, Habib. I like the way you do it, and I know that Remzi Avcı is a great surgeon, and he does really elegant surgeries with his technique. So there's no one right technique for this, I guess. So whatever you are used to, whatever you do best is the best for you, actually. And it depends on the case. Sometimes you can use one technique in one case and the other technique in other cases. What I do is I routinely do unimanual technique in diabetic retinopathy. What I do is I use 25 gauge surgery and do passive dissection after cutting the circumcision. I mean, in the peripheral, cutting the connection between the peripheral vitreous and the membranes. And I prefer to start from the periphery to the center. But if I can't find any plane in the periphery, sometimes it happens, then I can do the inside out technique. That's my, not the first choice, but sometimes you need to do that. And when I do it from the periphery, I start to do, I find a plane and I start to do blunt dissection with my vitrectomy probe and use cutter whenever I find a strong adhesion with the cutter. Then do just blunt dissection. And most of the patients can be managed with this technique, in my hands at least. But sometimes if you have any retinal break or something like that, you don't want to make any more traction over that retinal break area, then I usually convert to the bimanual technique to prevent, any additional traction on the retinal break area. Then I do use the bimanual technique. Or if I feel that I can't find any good plane in between the membrane and the retina, then I can't do, blunt dissection. In those cases, I may use bimanual technique, but it usually works in most of the cases.
So, Dr. Sengel, you're usually prepared for post technique, unimanual and bimanual. You are ready for post. Starting unimanual,
Yes.
and if you need to go bimanual, you are ready for bimanual.
Right.
Okay. Dr. Ramzi, can you show up your techniques and shifting from any other one? Because if anyone need to illustrate his idea by a video, it will be great. Dr. Ramzi?
Okay.
But let's ask Dr. Noor.
Let me show some video in my technique. Can you see my video now?
Yes.
Yes, we can.
Okay, just a moment. What happened?
Just open this.
Sorry.
Until the video of Dr. Ramzi comes up, Dr. Noor, do you do something different?
Actually, it was a very nice discussion, and I agree that in a diabetic eye, there's no single truth, no single the best technique. But I really enjoy your technique, Ahmed, because the circumcision is a must. For example, cutting the connections between the center and the periphery is a must in this kind of adhesion. But sometimes the eye was really available for that because there was a central traction with elevated, or you can find the elevated vitreous from the periphery. Sometimes there's diffuse connection with all the planes all around the retina, then you cannot do that. But in this eye, very nicely you disconnect it. And then what I do usually, I do a peripheral vitrectomy. I also do that. And especially my entrance area, just in case I go in and out, I want to try to avoid all the vitreous left in the periphery. And it takes maybe 5 to 10 minutes. Not vitreous-based shaving, but peripheral vitrectomy, let's say, and then go with the unimanual. I start always with the unimanual. Just in some cases that I decide this is a bimanual technique, so I should be going right away bimanually, put my chandelier in the first minutes, let's say. But apart from it, I agree that you did a very beautiful cutting of the delamination of the membranes with the cutter. It is not so easy, I think, and it didn't bleed. We were like, maybe you did an injection or not in this, because
yes, I did an injection.
You did an injection, yes, because it bleeds. In this, the thing that when it bleeds and it obscure your image, then and it's closed. This is the thing. I don't like bleeding during the surgery because it disables my vision, and then I cannot proceed with the surgery. So injection, I think you did something nice, and with the cutter and even 27 gauge now, I'm not available for the 27 gauge.
25. We
So
only use
for that
25.
eye, your technique is really nice, but
Thank you.
I mean, not single technique. I may do differently. So maybe we'll
I agree.
discuss after the video.
Dr. Ramzi, can you start your technique?
Yeah. So as I mentioned, we circumference separation of posterior partial detached posterior hyaloid, 360-degree. Then I start by manual from outside to in. Again, as you see with surgical plane. So this is some addition there, but you can see clearly with surgical plane with this bimanual work in this, as you see here. And we chose with base dissection after membranectomy. I do then laser, and I usually complete all the lasers. So this is another patient. You see, this patient has 0.8 vision. This one eye patient, but very severe membrane on the periphery, as you see here. Again, by
That's
manual
rare. Do you
dissection.
see this? Do you see this
The,
often? The peripheral
Not
membranes
that, no,
rather
no.
than
It's very rare,
very
Ahmed.
rare.
It's
Yeah.
very rare, but
Mm.
also it's very. Try to keep the crystalline lens in place. As you see, it's really difficult. We need third hands for this patient, and my assistant do indentation. Usually, I do my own indentation. As you see, it's a very thick membrane on the periphery, and then I decide to do retinectomy because otherwise, the traction will not resolve. And do laser and then fluid air exchanges patient. But again, by manual dissection, as you see, it's really easy to see all the connections with this technique, and you can remove with bimanual. So Şengül and Nur mentioned about unimanual. You know, there's some simple membranes. You don't need any things that you can remove everything with vitreous probe. So I could prefer unimanual technique, but in this patients, I always prefer bimanual technique. So not the other technique, but this is not mean that this is the best. But my best is this technique, and your other surgeon can have another best technique. But I'm really
Ramzi,
familiar with this technique.
Dr. Ramzi, you usually use the PFO as a third hand to assist you when you're peeling the membrane?
Not usually, but from time to time I use Mohammed
Hmm.
PFCO to stretch to attach to retina during the membranectomy, and also it really helps, but not in all cases. So this is another patient. But and in this patient, you can see it's very simple case. We don't need to do anything, just unimanual,
Yes. Yes.
just probe dissection. So I do not mention about membranectomy. I do not say this is membranectomy. Just simple, a kind of simple vitrectomy in this patient. But I think I have some difficult
But
case. Maybe I can solve.
I need to show up this case like the case you are showing to us, the peripheral membrane in a type 1 diabetic patient. This is like you are showing, but I deal with this unimanual by indenting the periphery. It's a still phakic patient and attacking this membrane only by the probe. But I think in this peripheral neovascular resistance, the bimanual is more difficult than unimanual because when you need to reach this far peripheral by forceps and scissor, you need it's more difficult, I think. This membrane, I need to ask you, you need to remove this membrane in this situation, Dr. Ramzi. What will happen if we keep it this membrane?
So in this case, Mohammed, I think we should remove all the membranes. We should do
It's a
this.
type 1.
We Yes, even in type 1, with the keeping the again, we start to do the sclerotomy like 4 millimeters far from the limbus, and with indentations, we should remove. Otherwise, distraction. So if this patient is one eye patient, and this patient, like my case, is good vision. I think this patient also has a very good vision. And
Do it
if
nice.
I think this, yeah, this is my idea. If we would leave some membrane, we do not release the traction, this will progress and may cause complete traction, and therefore in such patient I pay attention to remove membrane. This is very rare, so I have maybe less than 10 cases like peripheral proliferation,
But
but
usually
if I have this,
it ends
I
usually in
prefer to
breaks.
do. to remove all membrane. Sorry, yeah.
It usually ends in breaks, right? And silicone oil tamponade. Do you agree?
In my patient, I prefer gas tamponade because there is the laser was already performed other area of the retina. Only the lower temporal quadrant there was a retinectomy, and I prefer usually gas instead of silicone oil because I believe that gas has more tamponade effect in inferior retina compared to silicone oil. And again, I have different technique. I prefer gas more than silicone oil. Again,
We
this is
all
a big
prefer.
discussion, and also in our between our colleagues in Turkey. But I prefer gas in such patients.
Dr. Sengül, you have a comment?
Yes, thank you. So these are the most difficult diabetic cases, I should say, with peripheral membranes. So what I prefer to do in such cases is that if it is a very, a diffuse membrane in all over the retina, I mean in the posterior pole also and also in the anterior part, you have to do the dissection, of course. But if it is limited to a peripheral area only, and if the central part is more manageable, with more manageable membranes, and the retina is almost attached totally except that part, I can think about leaving that membrane there and do all the vitrectomy and shaving and lasering all around except from that localized area, and you can have a very good result. This is very similar to pediatric fever-like cases, familial exudative vitreoretinopathy-like cases. In those cases, you try to do membrane peeling as much as possible and leave the part if you feel that it may end up with a retinal break. If you feel that risk is too much, then you can leave it there and just do the laser and all those things, and you can avoid from retinal break. Otherwise, that retinal break may end up with lots of problems. But of course, leaving a membrane in that area has some risk, like rebleeding from that membrane. But if you peel the posterior hyaloid and the vitreous from the area around that membrane, it doesn't cause too much proliferation in the peripheral retina. In the other parts, I mean, it may stay there and it may not go all the other parts. So that's one of my advices for such cases, but it's really difficult to peel peripheral membranes, and in the talented hands like yours and like Renzi and all my colleagues, it may be easier, but it's really difficult. And especially for unexperienced surgeons, it's one of the best solutions to leave the part but before leaving that, you should do the complete vitrectomy as much as possible and do the laser enough and do the membrane peeling in all the areas. I think in unexperienced hands, one of the problems is to leave the vitreouschisis area in the peripheral, in the central or peripheral retina, because they usually cannot find the right surgical plane, and they may not do the total membrane peeling. They may leave some part, part of the posterior hyaloid in place, and it may cause contraction, and you can have lots of membranes, post-operational membranes. So if you peel all those membranes, you don't have reproliferation again and again.
Dr. Noor, you believe that you can leave some membrane in the peripheral retina?
Yes, I agree with completely with my colleagues, Dr. Şengül also. I had a case, but it is not with me now, just as a proliferation, but less active than yours. It's an active membrane that I would go to try to peel it. And I think you did it very controlled and nicely, but it's not easy. Sometimes it may cause a bleeding. What I do usually is my surgical technique that I have been doing it maybe for 10 years with a small gauge endodiaphragm. I just touch gently to the vessels, to the membranes from the inside, I mean. And then, like, it's very small power. it goes with contraction, and then with the heat energy, it elevates the membrane a bit. So you can find the plane, the delamination plane easier. For example, this can be done for that. And even with a bimanual technique, you did it very nicely again. I do the same, try to agree with unimanual, but if a bimanual surgery is needed, it's if you have a nice nurse, she can indent and you can do the bimanual. Sometimes it is.
Maybe I can say something. So there's in this page, so there's different uh, idea. I think again I would not agree to leave membranes in such patient, and usually this membrane may cause progressive traction, and usually this progressive traction may reach the macular area and may cause a traction on the macular area. Especially in type 1 diabetic patient, I think also in this membrane, when we live there, there is traction and tractional detachment. It's not possible to do laser easily. It's not possible to attach this area. And therefore, actually, again, I want to repeat that I prefer to remove all membrane on the periphery in this patient. So at least different message, but yes, this is really difficult case, and young, especially new surgeon, unexplained surgeon, should not start such kind of patients to the surgery. It is really, really difficult case. At least we can give this message to our young surgeon.
Yes, Dr.
Dr.
Noor.
Do you have a comment?
Yes, my last sentence, I agree. I will go to peel all the membranes, but sometimes, as Dr. Schengel also mentioned, you cannot do it. You may not be able to do it, but if you leave, it's a must that you should remove all the connections around that traction area. So all the periphery, the central area, the posterior hilus should be removed. And if there's no connection, only the traction membrane at site, and you do your complete vitrectomy, do the laser. And if you cannot peel and go on, dear Dr. Ramsey, sometimes it may be left, I believe. Not just the scenario is this. You do a very nice surgery, etc.
What's this type of Habib? What you are showing now, Habib? Is this a case of?
So this is the patient. That's my indication for bimanual surgery. She's a patient, 29 years old patient, type 1 diabetes, single eye, the other eye is lost, no PL, and this eye was PL, light perception, and we had to do surgery. This is the only eye. So my first question is, will someone enter without injecting before? This is a very florid membrane.
No.
You would inject.
This
All of
patient
you.
Yes.
needs injection, Ahmed. Really need
Yes,
injection.
I did that. So Muhammad, you would not do injection in this patient?
No,
You usually don't. No.
Wow.
I stopped injecting before surgery.
Okay. So if you don't do injection, I think you should do some cautery over the surface of the membrane before attacking it, right? You would do this, or you would just operate normally on this kind of membrane.
I will operate normally, and if I found uncontrolled bleeding, I just like I said, if the patient controlled by general anesthesiologist, it will go fine. If I have
Okay.
a more bleeding, I use the PFO to control this bleeding when I do surgery.
So this is my indication for bimanual surgery. From the start, I know I will use bimanual technique because the membrane is broad, and the connection is broad based. Not a lot of bridges to attack. And this was 2 days after injection. As you can see, the blood vessels are almost gone. The florid membranes are almost gone, and I had to attack it. And actually, I attacked it without not so much of bleeding. As you can see, the IOP is
Ahmed,
yes.
This is really very, very impressive. There is no vessel. So, what's
Yes,
dosage of your anti-VEGF injection? You need more
normal,
than regular
normal.
dose?
Yes, no, normal. But we have good placentas on.
Okay, okay, just sure.
It
But
was
it's
just
great.
2 days after. Yeah. So my fellow entered with circumcision and the peripheral vitrectomy, and then I entered with the bimanual. I will not bother you with the bimanual technique. You all do it very nice. I enter. Actually, the magnification on the ingenuity is enabling so much, and it makes it easier to dissect with ease. Um, I will fast forward this because I have a question after that. So I removed it all with with of course some slit breaks.
Because you are ROP
So I
surgeon, Ahmed, this is a type of membrane is like a piece of cake for you.
Not that much, but I can manage. So I removed it. I removed the membrane, but this is not my question. My question is this: is this this is subretinal, like a napkin ring fibrosis. So my question here: what would you do if you're in my place? Would you do a 180 degrees retinectomy and flip the retina and work from underneath, or um, you do multiple breaks or retinectomies to get under the retina? Because I tried to put I want to I want you to see this. I tried to put some PFC, and there is actually there were some subretinal bleed pre-existent, and when I put the PFC, the bleeds uh, become obvious, and when you remove it, the bleeds don't. So I put the PFC, but as were my suspicion, the subretinal bands are still contracted, and the retina would not flatten. So what would you do in this condition?
Dr. Ramsey,
I'm sorry.
So, it was really impressive, Ahmed. This is great
I'm,
surgery.
I'm not finished,
Uh,
but I want your
yeah,
answer about the yeah.
at least after membranectomy, you did a
Yeah.
good job.
Thank you.
So, may I ask a question? Did you have
Yes.
any iatrogenic tear or retinal tear
Yes.
when you finished
Yes.
membranectomy?
Yes. I'll be honest.
Yeah.
Where, yeah.
Okay.
Oh, very
So I do not prefer in this patient to do 360-degree retinectomy, never, because of the inflammation and the other problem. I prefer to remove subretinal um, hemorrhage subretinal membrane from small retinotomy and as much as possible. And also, I have a very special instrument, but it's not on the market yet. It's adjustable curve subretinal flute needle, and you can arrange the flute needle like you can go into the vitreous with a straight canal. Then when you move your hand in, it can go into the vitreous and curve the end of is a kind of memorial material, and you can aspirate some hemorrhage and the other exudations from far from the retinotomy. With this technique, maybe I can clean, and I try to remove membranes from small retinotomy, but not large retinectomy in this patient, Ahmed.
Mm. But don't you agree that if you enter with the forceps through the retinectomies, the small retinotomies, it will enlarge because of the manipulations? Because you need to enter with the forceps, not the flute needle.
So maybe, but prefer to do this retinectomy from the nasal part, not from the macular temporal area. But in diabetic patient, a large retinectomy, this is inflamed eyes and the retina is
I agree.
edematous retina. Therefore, I would not prefer again 360-degree retinectomy in this patient. But we just see now, we cannot see the perfectly the behind the retina, what's the thickness of the membrane, that's the severity. But
I
again,
will show
first
you.
I prefer this, but if it's not possible to remove, maybe as a last solution, I would do again not 360-degree, maybe like nasal 180-degree retinectomy and remove and do this. But that's the 180 degree, 360-degree retinectomy would be the last solution for me. But try to do my best before this in this patient for this large retinectomy.
Dr.
Dr.
Sunil?
Singer?
Um, this is really very difficult case, Habib, and you did very good surgery actually by peeling the membranes. But in such cases, the main thing is to avoid from retinal break actually. If you have so many subretinal bands and if you don't have any retinal break after peeling the membranes, you can leave it alone. So it may settle down, and
Exactly agree.
the
Yeah.
subretinal bands will not disturb too much. So you could leave if you didn't have any retinal breaks. But if you have a retinal break, it depends on where is the retinal break. If it is in the most proliferated area, I mean, the subretinal bands are over there causing, blocking the attachment of the retina in the retinal break area, then you may need to be more aggressive. But if it is in the, for example, I don't know, do you see my mouse? I think you don't see my mouse. Okay. If it is in the peripheral part, for example, and if you don't have too much membrane in a silent area, the retinal break, then you can clear the vitreous membrane and air retraction in that area. And if, especially if it is in the superior part, then you can just do the lasering and everything in those areas and put the silicone oil or any component, whatever you plan to do, and you can leave the subretinal bands there. But if it is in the most proliferated area, even if you do, those subretinal membrane extraction and all those things, I'm sure the patient also has intraretinal fibrosis, and retina must be very ischemic in such cases. So probably those eyes are maybe lost. There's a very high chance of losing such eyes. If you do the retinotomy, you will probably end up with, or even if you have an anatomical good result, your vision will be like hand motions or something like that. So that's
Dr.
my experience.
Singer, Dr. Singer, you see cases like this, and we kill the membrane without break, and the retina settle down in such a subretinal band?
Yes, of course, I see. I have some cases like, especially in Coates cases, you have so many subretinal bands, subretinal fibrosis, but it's exudating, and and also it can be tractional. And you just do the external drainage or sometimes vitrectomy without any retinal break, it settles down. And you have subretinal fibrotic bands. It is like, a rope, and retina is over there, but retina is still staying attached. So if you don't have any retinal break, just leave it there. It doesn't cause any problem. It is the same as the inferior conic
Pediatrics.
retinal detachments with subretinal bands. If you close the retinal break, you can leave those bands there. It doesn't cause too much problem.
What you are
I
doing,
don't
Ahmed?
want to be too much aggressive in such cases.
What you are
Okay.
doing, Ahmed?
First,
So
Dr. Noor, would you would like to say something?
Yes, I was going to say the same. If there were no breaks, I would leave the eye alone because that is the only seeing eye. The vessels are empty. The visual prognosis. I would like to see the outcome and watch. But in the
You
long
will be
run,
happy about it.
in the long run, yes, the fluid may be resolved, but not so quickly, but in the time. But if there is a tear, and if you can, if the area is without any traction again, if without any membranes, we can do the laser and then do the laser to the periphery. If we cannot laser, I think it seems to be attached to periphery. Cryotherapy we may add, for example, for the periphery, but it's a very difficult and rare case actually. And I wouldn't go for a large retinectomy. I was going to, if there's a break, I would like to squeeze it and remove it from a retinotomy for the first place. It may enlarge, okay, but at least if I remove it from a tear, for example, again, it is better than a large relaxing retinectomy in the side. Thank you for the case. Very nice.
Actually, I wanted to show you what I did. I'm actually comfortable with the notion that I can leave some membranes because I do some pediatrics, but I try to try leaving it. But when I put the PFCL, I am not sure if you can see this. The retina would not flatten. Sorry.
Why you are moving it fast, ya Ahmed? Keep it moving at the
Because of the
same.
time.
No, keep it moving. Keep it moving. Now we need to see what you are doing.
Okay.
Okay.
So I removed the membranes. So and then I saw this subretinal band. I thought at first that I can leave it. So I tried putting PFCL to try to flatten the retina. But when I put it, if you can see this, the retina would go on the side. So I decided to do small retinotomies to remove the subretinal membranes. But I had to do multiple ones actually because there was subfoveal membrane and there was the circular napkin ring subretinal bands. When I was doing this, I thought of that I could have done the 180 degrees retinectomy to avoid these multiple breaks. But now, when you're talking about that it's not that good of an idea, I am relieved. So then there is a subretinal band still. I removed the bands from the nasal side and the part temporal side, and there was a subfoveal band, if you can see this, and it is causing a fold in the fovea. So the problem here that I when I enter with the forceps, I was afraid that I might injure the choroids, and I would do and that I would do hemorrhage and complications of hemorrhage. I tried to see through the retina. I couldn't see clearly, so I put some PFCL to see the subfoveal band well, and I tried to enter. Now I'm seeing it well, but I'm trying to enter under the retina, but not to catch the choroid. I would just catch the membrane. Of course, the manipulations are painful for me, and I was thinking I'm causing so much trauma, but I couldn't do anything else. And then I removed the last of the membrane, and the retina was okay at last. And I did the laser, and actually a week after,
Hello. Hello.
and actually a week after, she's seeing 0.05. I hope she still she doesn't develop so much PVR, but I couldn't do the 180 degrees retinectomy. I thought of it, to avoid these to avoid these breaks, but actually I did what I did.
But
So
Ahmet, I congratulate you. It's really good surgery. But finally, as a message, so you push us to do large retinectomy, but we said that no. But at the end, you did not do large retinectomy. You did small
because
retinectomy, as we suggest,
it
and
was
get a
not a trick.
success. So
It was not a
why
trick.
you
No, no,
discuss for a long period of time? So
no,
so as
no, no, no.
as a
Because
summary, we
because
don't
I
need
thought
to
that
do large retinectomy.
because I was thinking that I'm doing so much damage with the multiple breaks I'm doing, as Dr.
No, no,
Single
no. Still,
said,
I believe that you're on the right way.
and
We are
and
agree with you.
also
So I did a very good job.
what about the choroidal injury? What do you do about that? What techniques do you do for seeing for entering under the retina but over the choroid? You see, you do any tricks to see the levels? You do
Push your
magnification?
focus.
Use a lens, macular lens or something?
No,
You
no, I
push
think
your
your technique is really good. PFCL injection is really helps us. It remove the bleed and the others, and maybe I do the same things. I inject PFCL until the edge of the membranes to be able to see the membrane, because if there's some hemorrhage or there, you cannot see the tip of the forceps where you catch, and maybe you can make a correct damage. But PFCL injection is really, really good idea. Except this, I have no another method, another technique that I know.
Okay. Thank you, Ahmed, for this impressive
Thank
surgery,
you.
by the way, and you make it like fantastic. Doctor, can we shift it for if you have anyone have a clap for his technique to dissecting membrane or not, or we can shifting for a post-operative issue for combinating and discussing about when you decide to use air, when do you decide to use gas, when do you decide to use silicone oil in a diabetic vitrectomy
I just
kids.
want to ask my usual question. What do you do about disc bleeding, everyone? Because this is my nightmare.
Disc
I
bleeding.
when
What?
when
What?
I find it, yes.
Can you repeat question again?
What do you
Disc
do about
bleeding.
disc
What?
bleeding from the disc?
Ah,
I can
yeah.
answer if you.
Yes, yes, please.
What I do is I try to, if there's a, neovascularization, a real vascularized membrane over the optic disc area, and if I feel that it may bleed, I usually try to leave the membrane over the optic disc area after dissecting from the surrounding. And if it bleeds, still the membrane bleeds, I do cautery to the membrane, not to the disc, of course, but to the membrane. And if it doesn't look so florid, but if I do the membrane peeling over the optic disc, then if it bleeds, what I do is I, of course, increase the pressure in the eye first, wait for some time, and I can also press over the hemorrhage area, I mean the bleeding area, with the tip of the vitrectomy probe. It helps a lot. And I don't, of course, do cautery, but these are the main things that I do in such cases, increasing the pressure and pressing over it.
Dr. Ramsey, you can leave the desk stock over the desk.
Yeah.
You can leave the
So,
strap.
Schengen summarized everything about to stop the hemorrhage on the disc. I do, if it's not possible to remove, if the remove gum membrane will give some damage to the retina, I of course prefer to leave a stalk of membrane on the disc. But usually, I do my best to remove the membrane. If it's not possible, I leave that. But if I leave, I remove all membrane from around the disc. I do not leave any connection between membrane and to the periphery of the retina around the disc, because and this connection make cause a traction after the surgery. But rarely I leave the membrane on the disc. Again, mechanical pressure in my hand is really very effective to stop bleeding on the disc bleeding. I apply like 1 minute mechanical traction. Together, as Şengül said, is increase of intraocular pressure. It usually works, Ahmet. It usually works. Rarely you may have some problems. This is same that I say the same thing like Şengül.
I have lost 2 cases from this. So
do you have another tip for disc bleeding?
Me. And also, apart from it, for example, we can inject some decoline on top of the disc after mechanical pressure.
that what?
It's heavy liquids. You can
Okay. Yes, okay.
and still with pressure with the instrument. But when you leave the instrument, then it starts sometimes bleeding or oozes hemorrhage after some time. So decoline helps to control the ooze, not the fluorid hemorrhage.
Dr. Salam once told me about the fibrin glue, the tissel. Have anyone used it with disc bleeding?
No.
If it still goes on, I mean, the bleeding, you should check the blood pressure of the patient.
I always do.
So let's summarize the rest of point about the post-operative, the tamponading. Dr. Şengül, you have a preferable tamponading for diabetic vitrectomy with a membrane dissection, or you decide according to every case. You put air, gas, silicone. In a membrane dissection, if you have a membrane and you are dissecting membrane.
So you mean about the choice of tamponing?
Yes.
Okay.
In a tractional fibrovascular traction membrane.
Tractional retinal detachment case. Okay. So if I feel that the retina is too ischemic, and as Habib's show, too many subretinal bands and empty vessels, things like that. Even if I don't have any retinal break, I do use silicone oil in such cases. I try to use, because in such cases, some atrophic retinal holes may be present that you don't realize, and you do laser, but if you don't put tamponate like silicone oil, they may cause rheumatogenic retinal detachment. So if I don't rely on the retina, if it is too ischemic, then I prefer to use silicone oil. But if the retina looks good to me, even if I have the retinal break, I use gas in such cases. So
And you
that's
remove the
my
silicone after
usual.
what time? How much?
I usually remove it within 3 months. 3 months.
Dr. Ramzi, let's make these questions more specific. If you have a case of tractional retinal detachment and you're dissecting the membrane and you have 1 or 2 breaks, can you decide to leave this patient on air or gas, or once you have a break, you decide to put a silicone oil? Dr. Ramzi.
Me. So I couldn't follow your question exactly because there's some interruption of your voice. Could you? But as I understand, yeah.
I was asking if
maybe
there was a TRD and you moved the membrane, but there were 2 breaks, and what?
You have 1 or 2 breaks.
Yeah.
Do you leave this patient on gas or silicone?
Yeah. As Şengül said, in ischemic retina, I usually prefer silicone oil. If the patient has fluorid retinopathy, if the patient has neovascular glaucoma, I again prefer silicone oil in this patient. Except this, I prefer gas tamponade, a patient with several breaks. But if the patient has no breaks, exist during membranectomy and the no previous breaks, but after membrane removing, there are loss of traction and subretinal fluid. The retina is not attached. In this patient, I usually do not use any tamponates and leave the patient at its position and Usually it takes time, but if there is no break, retina is attached in several weeks later, and step-by-step attachment we can observe. In summary, usually prefer gas if the patient has break. In ischemic fluid and neovascular glaucoma patients, I prefer silicone oil. And if there is no break, but still there is detachment after membranectomy, I do not prefer tamponade material.
Dr. Noor, if you have a break, you can use gas in diabetic cases?
Yes, if you did a good complete vitrectomy, the retina is attached without any vitreous, you did the laser put, and around the tear also good laser, you can leave this with a gas. But if it is an only seeing eye, I would prefer silicone especially. If I mean, apart from if the patient is usually coming from abroad sometimes or other cities, so you need to, in the real experience, real life, you need to keep silicone on sometimes. But I agree with my colleagues that fluoride retinopathy, I prefer usually silicone oil. Apart from it, if the patient is faking and cannot obey, she is a working patient, and sometimes they may prefer having oil in the eye to be active earlier sometimes.
Let me ask you a question, Dr. Noor. If you have a case of TRD, traction membrane, and you remove your membrane without break, but the retina still detached, you
Mhm.
can leave this eye like Dr. Ramsey on a fluid-filled eye or an air tamponade. How can you do a laser? You doing it after that, after the retina was be flattening, you do a laser or what you are doing?
Usually there is some fluid left in the central area, in the macular area. If there's a traction retinal detachment, you peeled all the membranes. There is some fluid, but it is just collected in the macular area, central. So you do not laser that area. What I do, you can do the laser with the indentation, self indentation. When you indent, the fluid is not in the periphery or even until to the mid periphery, around the arcades. You can do your laser in the surgery. If I can do the laser, and this is usually done, so I may leave the eye without any tamponade or air, for example, or gas. But that is my question to all my colleagues. Pardon. Please go on. Thanks, Ab.
Uh,
May I show a case to answer your question, Mohammed?
yes.
Uh, I think this patient exactly describe your question. So, in this patient has some membranes. We remove all the membranes, but there's still tractional retinal detachment in this area. Again, by manual dissection, maybe we can move this area. So it's very short video. So again, as you see, there's still traction retinal detachment on the posterior pole, but we did laser around the traction detachment area, and there is still little subretinal hemorrhage. But this patient, there is no retinal tear. I leave this patient like this without doing laser around this area. But then, if several weeks after surgery, when the retina is attached, you can do laser this area, external laser. But I do not prefer tamponade material. Also, I do not to do laser in this area. Do not. We can leave a small area without laser. So the other areas lasers, and this may and be enough to reduce the activity of the retina. I think.
Okay. So we can delay the laser after the retina to be attached this 3 4 weeks after surgery. This is no problem.
Yeah. Yeah,
Yeah,
three,
okay.
4 weeks after surgery, because usually a very limited amount of retinas we live unlasered after just after surgery. So several weeks later, we can do laser this area. Otherwise, we should remove the subretinal fluid with small retinotomy, and then do the laser, then gas tamponade maybe. This is another solution. But I did this also, but in my recent cases, I do not prefer retinotomy and remove subretinal fluid. I leave it like that. It takes maybe more weeks to
Sometimes it
resolve
takes a
by
lot of
itself
time.
spontaneously, but it works, and we can do laser later on.
Dr. Sungul, you have a comment on this?
Yes, actually, if it is a localized retinal detachment area like Dr. Remzi has shown, I leave it like that, and it usually doesn't cause any problem when the retina is attached. It may take maybe like 1 month, 2 months sometimes, but
Yeah.
it usually doesn't cause any problem. But if it is diffuse retinal detachment all over the posterior pole, and if it is a very ischemic retina without any previous retinal pararetinal photocoagulation, then in such cases, even if you don't have any retinal break, I usually do a small retinotomy to drain that very dense
Visit fluid.
subretinal fluid, because they are usually very chronic and it usually takes a lot of time to be resorbed. And also, in such, very long-standing cases, you may have some atrophic retinal holes or something like that. So I usually prefer to drain such subretinal fluid during the surgery, and I usually try to attach the retina during the surgery and do laser in all the retina, and then put whatever you want, silicone oil or gas. It depends on the case.
I had two cases
So I prefer.
that it took a year for the subfoveal fluid to resolve.
Yes, that was my question for all of you. I mean, do you drain intraoperatively vector area, even that chronic fluid, or do you leave like that? It takes a long time. So, do you drain, Ahmet, now?
I if the fluid is connecting, if there is subfoveal fluid and the fluid is connecting to some fluid outside the macular area and the arcades, I would do retinotomy and try to remove actively the viscid fluid, because it takes a long time and the patient is frustrated after the surgery. But if it's a small subfoveal fluid and there is no empty site except in the posterior pole, I don't do.
Mm-hmm.
Okay, I need, because we don't need to make you spend more time because we are late now in Turkey. But I need to hear from both of yeah, every one of you a clear message for a young ophthalmologist who are starting doing a diabetic vitrectomy, especially fractional membrane. What's your clear advice for him, Dr. Ramsey? Starting with you.
I can say for young surgeon too, they should pay attention to standardize their surgery. That is very important. All step of surgery, not only traction detachment, all kind of surgery. I think at least in my hand, I do this. And when you get optimize surgery in your technique in another different disease, you can get really a good success. But again, if you have a technique that it's good in your hand, but you don't need to change, you don't need go to other technique, new technique, another. You can try, but for the surgeon to get a good experience means to do these techniques many times, and therefore again optimization of surgery, again the standardization of surgery or surgical steps is very important. At least in my practice, I'm doing this to reduce the complication.
Dr. Noor, need you from you a clear message for a young ophthalmologist who are starting doing diabetic vitrectomy.
Vitrectomy. It's. I think the best is that every diabetic eye can be different. So we have to be. We can perform elective surgery, as I told before, and it is the ideal to prepare the best conditions, the best in your mindset in the OR, like what to do. You have a plan, surgical plan, and then be ready for the complications. Be ready with all the equipments, anesthesiologic, the systemic preparation of the patient. I think it's really very important and affecting your success apart from your surgical technique. And maybe if you are really young and starting new, you can do your ultrasonographic evaluation before the surgery to see the connections, to be well prepared for again do surgery. So every diabetic guy, there is no single best in, I think, diabetic retinectomy. And I think when you stepwise, you should go, and you should be ready to, when you know that you leave, or you leave it to your mentor, for example, and then you will enjoy the vitrectomy. I think it's very enjoyable surgery.
It is.
Dr. Single.
When it's not complicating, it is.
Okay, sorry. They are all so nice, nice advices. What I would advise to the new starters is start with pseudophakic vitreous hemorrhage cases. Those are the best cases which end up with more
Best results.
with best results, and also the patient is more satisfied. And secondly, please, when you are deciding on the indication of the surgery, do the correct decision. This is the first thing. And they shouldn't be too brave to do the surgeries in good seeing eyes. And pre-operation preparation is very important, as we discussed before. So they should be very insistent on this. And they should avoid combined surgeries, especially at the beginning. They shouldn't do combined phaco-vitrectomy. Try to preserve the lens all the time. And they can leave some membranes if you feel that it may cause some retinal breaks. So always try to avoid from having retinal breaks. And they can leave some membranes. It's better than leaving some retinal breaks. So I think these are the most important things for the beginners.
So I want to say, just want to say that we have had a wonderful time. I had so much fun with you guys, and you're such fantastic surgeons. We all knew that from before, and it's more obvious now. So we had so much fun. Thank you, Dr. Ali, Dr. Noor, Dr. Singwell.
We are sorry,
And we hope to
for,
see you again in another episode of Al Kahwa, inshallah.
thank you, Dr. Ramzi. Thank you, Dr. Noor. Thank you,
Thank
Dr.
you.
Single.
It's
We
our
are sorry.
thanks.
We are sorry for make you late till this
But we had
time.
so much fun. So much fun. So much.
Yes.
I enjoyed
When
a
I
lot
come to Egypt,
also. Thank you.
Mohammed, when I come to Egypt, you will order Turkish coffee after me, okay? Because this is
Yes,
Sunday,
we
there's no coffee here.
I left some pictures, professional pictures from Muhammad.
We should order them when they come to Turkey. It's a Turkish coffee. Come on, Rengi.
Yeah, but they prepare Turkish coffee
It's
better
free
than
for all.
us,
Free
Şengül.
for
You
all.
don't know.
Of course, of course, of course.
Thank you guys
Okay.
so much.
I enjoyed a
Okay,
lot. Thank you, guys. You have
okay.
done a
Really,
great
we
job.
enjoy a lot. It was very good discussion. Thanks,
Thank
thanks
you.
for your
Bye.
effort.
Very
Thanks.
nice discussion.
Bye-bye.
Very
Thank
nice.
you.
Good night.
Good
Share.
night.
Good night.
Good night.
Good night. Bye.